Sejam bem-vindos à Academia VBHC. Eu sou Marcia Makdisse, sou cardiologista especialista em Value-Based Healthcare e cofundadora da Academia VBHC. Hoje temos o prazer de ter conosco Rik Renard, que é enfermeiro de formação e que se formou com distinção na Universidade de Leuven-Limburg, da Bélgica, em 2018, e que tem um mestrado pela Universidade de Ghent em Gestão e Políticas de Saúde. Atualmente, ele é gestor de parcerias de VBHC na AWell, que é uma empresa focada no desenvolvimento de linhas de cuidado digitais e que auxiliam os hospitais da Bélgica e da Holanda na implementação de linhas de cuidado e de estratégias de VBHC que incluem a coleta de desfechos, utilizando standard set do ITIOM, sempre que elas estejam disponíveis. Bom, hoje nós vamos falar com o Rik sobre 3 pontos. O primeiro é entender um pouco essa carreira que começa como profissional de saúde, como enfermeiro, e que depois cria um foco em Value-Based Healthcare, o papel dele auxiliando as organizações na implementação de VBHC e, finalmente, saber um pouco mais sobre aquele artigo provocador que ele publicou no LinkedIn em dezembro, chamado O Problema da Coleta dos PROMs, ou dos desfechos reportados pelos pacientes. E ele faz um alerta de que nós devemos coletar PROMs desde que a gente tenha um propósito, desde o começo, de como utilizarmos esses PROMs para, de fato, melhorar as linhas de cuidado e gerar valor para o paciente. Rik, welcome, and thank you very much for joining us today at the Academia. And to start this conversation, I'm really curious about your career as a nurse and how you came to be interested in value-based healthcare.
Yes, thank you. Thank you for having me. So indeed, I first studied nursing, and after nursing, and I did a lot of internships. I said to myself that I want to be in the future. I want to be much more than a nurse, and I want to have impact on a broader level and on a population level on patients. And that's why I started with my master's degrees, management and policy in healthcare. And that's the first time I got in contact with value-based healthcare was for my master thesis. And also my professor there was always talking about value-based healthcare. And to be honest, I didn't understand the point of value-based healthcare. I was like, why do we need it? And then it finally clicked to me when he was saying that, like, we are at the moment living in like a fee-for-service world, at least in Belgium we do, and everything is based on getting more money to the hospitals and doing more services for the patients, and nothing is based on outcomes. And I thought it was quite weird to organize our care system around services and not on outcomes, and have systems like increase their outcomes and make sure that they want to increase their outcomes and not increase the money they earn from doing more services. And that's why I joined a patient hackathon of Pfizer in Brussels. And that's where I met Thomas van de Castele, it's our CEO at AWell. And he was also talking about, like, the reason why we started AWell is because we are so fee-for-service focused, but we are not outcome focused. And that's why we started AWell. And I was like, this is a match made in heaven, because I was writing my thesis about patient journeys, and he was talking about value-based outcome healthcare care pathways. And yeah, we clicked there and we talked about it a lot. And I joined AWell as working student, and then I joined them as pathway builder. So where I built like more than 50 value-based healthcare pathways and collected a lot of outcomes. And now I'm more and more getting hooked to the value-based healthcare world and the ecosystem, and meeting people like you, and discussing the topics and how we can improve the outcomes for the patients, and really improve the outcomes that only matter to patients. So listen to the patient and improve their wishes, let's say.
That's great, Rik. And it's very important for our nurses in Brazil to understand there is a new career related to value-based healthcare, and so much we can do about it. We do believe that the healthcare professionals have to be educated in order to lead this healthcare transformation, right? So tell me more about your role at AUL in creating those, in building those care pathways and helping organizations and healthcare professionals to move on with their value-based healthcare strategy.
Yes. So what I believe, and I have a strong opinion here, is that the change needs to come bottom up. So it's not the management hospital system that's saying like we're going to move forward with care pathways or collect outcomes. No, it's from the floor and the physicians and the nurses that are saying like we want to improve our processes. And that's when they come to AWEL and they say like, I've seen you working on care pathways, can we have a chat? And then we have a chat, we show our platform and we show the vision we have. And when the vision matches, so meaning that when they also want to improve the outcomes of the patient, so this means that, for example, when they want to collect the outcomes but don't want to take actions based on the outcomes, then there is no match. Then the first thing we do try to do is educate them about the importance of collecting outcomes, but also acting on those outcomes. So when the vision is clear and we are aligned on the goals of the project, then we co-design care pathways. So we work together side by side. We go to the hospital and we have, for example, a patient journey mapping exercise where we map the care pathway, and all the pathways that we created first and before the mapping exercise, we look if there is an ACHOM standard set available and see which outcomes we need to collect to benchmark those data abroad to other hospitals and maybe worldwide. Because that's also a problem that we've seen, is that they already have a care pathway in mind and they maybe already using some, but they're not collecting the right outcomes. So their data is siloed. They can use it for their own hospitals, but they cannot use it to improve other hospitals and other organizations as well. And once we design the care pathway together with the physicians, we go live, we include some patients, for example, 10 patients, we listen to their feedback, and based on their feedback, we change the flow again. And then when we think it's good, we include a lot of patients, and then we see the outcomes we collect and see where we can improve. And I think that's also something nurses of the future and doctors of the future and current doctors can do at the moment. Don't be happy with the status quo you're living in. Look at your process and try to optimize it. And you don't need a tool like AWEL to start doing so. You can also already look critical to your own flow and see things like maybe we can do those things differently and improve step by step. And I think the most important lesson I would share with the audience is that start as soon as possible. You don't need to have like one big amazing care pathway finalized with so many different opinions. Start with like collecting like maybe 1 or 2 questionnaires or validated questionnaires, and then start building on top of that. Start what we call it start slow and then aim big, of course.
That's great. That's one of the principles for value-based healthcare implementation, right? You cannot change this whole complex system at once. But then, of course, digital tools are very important. And I really want to emphasize what you have just said, Rik, because we do not need all the technology in place in order to start changing how healthcare this system is, the status quo, as you said. So now let me ask you about this provocative article you published on LinkedIn, the problem with patient report outcome measures, where you basically make a call to action about the purpose of collecting outcomes. And you say that if this purpose is not about improving care pathways and patient outcomes, then we should stop collecting them. And that is really, really interesting, because we keep telling people you have to collect outcomes, but then you come and then you say, okay, but do it with a purpose from the start, right? And I could see a lot of support to your comments. So please share more of your thoughts on that.
Yes. So like mentioned, we have like, I had a lot of contact with different stakeholders in the healthcare ecosystem, and they all come to us and say like, we want to collect patient-reported outcome measures. And then you ask, why do you want to collect them? And then they say like, yeah, because we want to. And then they don't have like a solid answer why they want to collect them. And then it's like, yeah, I want this to have a presentation on a conference. And then we stop talking and like, let's take a step back and like really understand why you should collect patient-reported outcome measurements. They are clinical meaningless if it's not used for what they're meant for, and it's like improving the outcomes that really matter to patients. So it's not for talking on a conference. Of course, it's nice, but it should not be the purpose. It's not because you want your management, healthcare management team wants a fancy value-based healthcare dashboard. I want to say to the news agents like, look, we have value-based healthcare and we embrace it. No, it's like meaning that you want to improve the patient's outcomes. So meaning that once you collect those outcomes and the patient takes time, because collecting outcomes take time and it asks effort from the patient, that you also look at the data. And then you can, for example, when you have a consultation with your patient, see like, I've seen that you have this complication and this complication, and we will do this and this to prevent this from happening. But if you collect your outcomes and you're not discussing these outcomes with your patient on a patient level, then I will ask and stop doing and take a step back and like really collect the outcomes that you're happy to take actions to. So don't collect hundreds and hundreds of outcomes if you're not able to act on them. I think that prompts should drive actions and decision making. It's not only for a fancy dashboard or anything else. And it's also a problem we have in healthcare. We have so many data, but we are information poor, meaning that we don't know what actions we need to take on those outcomes, let's say. And that's also how I end my article, is that maybe just track key patient-reported outcome measurement that you're willing to collect and willing to take action to, instead of collecting hundreds and hundreds of outcomes and not looking at your results.
That's great. Então, como vocês puderam ver, a coleta de desfechos aí vai continuar sendo um componente fundamental da agenda de valor. O que o Rik nos trouxe é que nós precisamos ter em mente que somente coletar desfechos não significa que você abraçou a causa do VBHC e que você está gerando valor para os pacientes. A coleta é, de fato, a coleta de desfechos é o primeiro passo, mas ele precisa, desde o começo, estar atrelado a um propósito de melhorar a qualidade do cuidado, melhorar os desfechos e gerar valor para os pacientes. Portanto, se você se faz aquela pergunta, o que nós faremos com os dados uma vez coletados, e se a resposta for nada, ou apenas para coletar para uma conferência, ou apenas para um relatório ou um dashboard, então pare de coletar desfecho, repense a estratégia e recomece selecionando quais são os desfechos que realmente importam para os pacientes e o que, desde o começo, qual o plano desde o começo para que se utilizem esses desfechos no nível do paciente ou para a melhoria dos cuidados em saúde, dos cuidados prestados. Então, Rik, thank you so much for your time and for sharing your thoughts with us. I believe this call to action, we get our followers to reflect on the purpose in regard to collecting PROMs. So thank you so much for your time. It was great. And we are going to keep following you at the LinkedIn. E a todos vocês da academia, obrigada pela companhia. Continuem seguindo a Academia VBHC em nossa plataforma www.academiavbhc.org e em todos os nossos canais. Thank you again, Rik.
Thank you.